We really appreciate Chris coming today and presenting for us. We do miss Jean, but Chris is a healthcare industry veteran with 15 plus years in the industry, combining unique perspective of avoiding physician risk and liability with opportunities for optimizing reimbursement. We love it when he presents for us, and he's highly sought after lecturer, and his expertise in building highly integrative palliative care partnerships has been integral in transforming the way healthcare is delivered in the most vulnerable patient populations. So everybody welcome Chris. Take it away.
Thank you, Mindy. And this is as informal as possible. So if you have a question, please either use the hand raise icon or just unmute yourself and ask the question. Happy to take questions throughout the presentation. There have been a number of changes to the code sets we're going to talk about today, and we're going to preview some of the things that are in the proposed fee schedule that should be out next week, if not by the end of this week. So again, if you've got questions about these things, please do chime in. There are still providers today that haven't had the opportunity to fully educate themselves to some of the changes that took place to the evaluation and management services codes in 2021 for office visits, and then the changes that took place in 2023 this year for the rest of the base code sets for evaluation and management services. So hospital visits, SNF visits, and for anyone who does home or ALF type visits as well. We're going to talk about those changes, talk about some ways to leverage the opportunities from a coding perspective that we now have. They made some of the codes much easier to attain or substantiate, if you will. We'll talk about how to do that via either time-based billing or medical decision making. I know most office practices are billing based on medical decision making or complexity-based billing, if you will, and not really concerned with time, but the time-based component is important with some of the changes they've allowed, and it really can serve as a backstop when you have some less complex patients that have an extraordinary amount of time you spend on them preparing and following up. And then again, we'll talk through some important changes that are proposed in 2024 and some recent law changes that affect all of us here in the state of Florida. So without further ado, the evaluation and management service codes, which represent a huge swath of the revenue that our practices buy and bill for, right? At the end of the day, the services we render in the office and to patients had some overwhelming and sweeping changes over the course of the last 2 years. And the AMA, in conjunction with CMS, Medicare, Medicaid, right, really did a number on changing the documentation requirements and allowing for what some might call a lot smoother incorporation of what the doctors are actually doing with patients to drive the level of coding, right? And nicely for evaluation and management services, again, whether they're in the office, whether they're in a SNF or in a hospital setting, right? The medical decision-making component, so the overall complexity of the visit, what we're doing for the patient, what the patient presented with, the amount of data we're reviewing, and the overall risk to a patient is really what is now driving the code substantiation from a level of coding perspective. If not that, time. Right. And what's important to note, and I'll repeat it a few times, is that whether or not clinician, physician, non-physician practitioner, right, substantiates their visit, and the level of code based on decision making or time is up to that clinician. And it should be the route of substantiation that provides for the highest level of remuneration. Right. So if the medical decision-making component substantiates a level 2 visit, but the time, and I'll give examples of all of these, the time substantiates a level 4, we're going to want to build a level 4 because that's what we're allowed to do. Why would we give up the revenue, right? It means that we met the code's criteria on time and we're able to bill it. And conversely, if we have a visit that the time component for a level 2 might only be met, but the medical decision-making complexity of the visit is moderate, then we would bill for the level of code that is substantiated with moderate complexity, which is generally what we would consider a level 4 visit, right? The nicest change, I think, for us is that the counting of bullets for history and exam components are no longer required when it comes to substantiating the visit code. So for the better part of the last 21 years that I've been doing this, the level of service, right, a level 4 new patient office visit, right, was substantiated with the amount of history the doctor and MA might have taken, the amount of physical exam, and we literally had to go in and count all of these bullet points. And unfortunately, for years, right, if the doctor missed documenting a bullet point, then sometimes those codes, whether they were level 4s or 5 visits, would be down coded all the way to a level 3 based on the coding rules, right? Nicely, that's not the case anymore, though. The amount of history and exam is really only what's now clinically appropriate, right? And so some level of history or exam needs to be accounted for, but right, it's only the amount that is clinically appropriate in the visit. If it is only appropriate for you to get a past surgical history on a patient, and maybe the history of present illness of what's going on on today's visit, that's all that's needed to be documented. We don't have to get a family history or social history if we don't need it, right? So if we have a chief complaint, a reason for the visit, some level of compulsory history exam that is clinically appropriate, that's all we need. And what's driving now the coding is the medical decision making. And then if we're using time, we'll talk about the activities that can be counted in the time-based coding, right? There were a number of new time ranges and thresholds from office visits to hospital visits. What we're going to talk about today is what's currently in place. Understand that the thresholds we're going to cover today for office visits, clinic visits, are going to get eliminated in 2024, and they'll just be standard times, which is nice. We'll go over the AMA's level of medical decision-making table and guide so that that's clear. And again, we'll go through some of the time activities. For those of you that are coders on this session, it is imperative that you look at the introductory guidelines, right, and parenthetical notes for the code sets. They all changed between 2021 and this year. And so for those of you that rely on that information to help substantiate those services and the reasoning behind that to your physicians and non-physician practitioners, it's always helpful to have an understanding of what guidelines actually changed. The hospital and outpatient observation care services. So for those of you that are admitting patients to hospitals or seeing patient in the inpatient setting, whether you're seeing them in observation or as inpatients, right? All of those services were combined into one type of code set, right? The 99221 through 99223 and 99231 through 99239. So initial and subsequent visit codes, right? There isn't a separate code set for observation care services. The observation codes were deleted, right? Consultation codes, for those of you still getting paid by United or the few payers that recognize consult codes, those guidelines were revised a little bit. And as you can see, the level 1 consult codes went away. Not that I can remember the last time anyone billed a level 1 consult, but those went away for both outpatient and inpatient consults. Remember, those codes are not accepted by Medicare, but they are still paid by a few of the commercial payers. And when they are paid, they're generally paid higher than some of the other code set codes. The nursing facility visit codes, 99304, 5, and 6 for initial nursing facility care, and 99307 through 99310 for subsequent nursing care. Those guidelines were completely revised, and the annual assessment code was deleted, right? So now it's just initial and subsequent nursing facility codes, whether they're residential or SNF patients. And perhaps the biggest change was to the home and ALF suite of codes, right? Those were combined into home or residential services, which are now 99341, 2, 4, and 5, and 99347 through 50. It's not a typo. The 99343 was deleted, right? So there are 4 new patient visit codes in the home or residence and 4 established patient visit codes in the home or residence. Those guidelines were revised to include really all residential services, right? So whether a patient is a transient patient in a hotel room, in an ALF, independent living facility, or private home, right? Those codes are all the same code sets. And what's going to determine whether or not you use the 4.1 through 4.5 or 4.7 through 5.0 is whether or not they're a new or established patient. It is important to remember, right, that the medical necessity requirements for these visits did not go away or change. All of our visits, in order to be billed, have to be medically necessary. The history of present illness and assessment and plan really do the best job of capturing medical necessity, so please make sure those are clear. And the modifier rules didn't change, right? So any of us billing modifier 25 when we're reporting an evaluation and management service and a minor procedure that has a global period that is impacting the E&M visit, right? The modifier rules didn't change. So the E&M still has to stand alone and be separately identifiable. And the procedure, when it's billed, right, would have the documentation to support its services. Some of the other things that took place when they made these coding changes were coding definitions for some terms and language, right? We'll talk about that in a moment when we get through the medical decision-making piece, but stable chronic illness in the coding world means something that the term stable chronic illness may not mean for someone who isn't coding a record, right? So we'll talk about that, and we'll get into some specifics about when problems are able to be counted or not counted. But by far the easiest way to substantiate codes is the time-based component, so we're going to look at that first. And again, just because the codes have a time value doesn't mean you have to meet that time value if you're substantiating the visit based on medical decision making, right? So if a code has a time value of 40 minutes, but we're getting the work completed in 20 minutes or 12 minutes, and the medical decision making is driving the code selection, that's okay. This is just if we're going to use time. And because the components of time changed, we are now able to use really all of the time on the date of the encounter that is time associated with our brain power to any specific patient. So it's the prep time. It's the time of reviewing old records. It's the time speaking to your staff about obtaining old records on a specific patient. It's the time that's spent performing, of course, the exam and the interactive time with the patient. It's the time spent counseling or educating that patient or family members. It's the time spent writing orders, tests, procedures, referring out, communicating with other professionals. The time spent documenting in the EMR, if done on that date, right? Anytime independently interpreting test results or communicating with family members, as long as we're not separately reporting the interpretation, right? We're able to include that time, and any interactive care coordination that we're not also billing for, right? So if we're billing for care plan oversight and we're logging minutes for that, that would have to come out of the accountable activities, right? Aggregate minutes. If we were billing for advanced care planning, the amount of time we spent in advanced care planning would come out of the aggregate minutes, right? So if we spent 3 minutes prepping, that's a bad example. 15 minutes prepping to see the patient, 10 minutes reviewing old history, so that's 25 minutes. If we spend 10 minutes with the patient, that's 35 minutes. Then we spend another 10 minutes ordering meds and documenting in the record, right? 45 minutes total. Of those 45 minutes, we spent 20 minutes in advanced care planning that we're billing for. Then our base visit code goes from 45 minutes to 25 minutes because we've got to back out the 20 minutes of advanced care planning we're separately billing for, right? But if we're not separately billing for anything else that takes time, then the entirety of our minutes or hours spent on a specific patient on that date is able to be included when we're substantiating the visit level. And I'll give some examples in a moment of how this is impactful. And it used to be the case that when we were going to use time, that we had to qualify the visit with greater than 50% in counseling and coordination of care, and we were only able to count time that we spent face-to-face with the patient, right, in the room with the patient, or in the hospital or SNF on the nursing floor or unit, right? Not the case anymore. Now it's all of the time we spend. So if our physician wakes up and they start prepping to see patients on the app, on their EMR portal through their phone in the morning, and then they get to the office, so they spend 10 minutes in the morning reviewing records that they needed to review, and then they get to the office and they spend another 10 minutes talking to staff about prepping for the patient, and then they spend 15 minutes with the patient, right? That all of that time would be able to be accounted for. That's 35 minutes right there. If they spend another 15 minutes documenting at the end of the day after the patient is gone, right? Now we're at 50 minutes for the visit. So important to know that all of the activities can be countable, which is why I think time is important as a backstop in case you have patients that from a complexity perspective might not get you to the level of code the time will get you to, right? So as long as we're not counting time that we're reporting with separate CPT codes, as long as we're not billing for travel time, right? If it's time we're spending on the phone with the infectious disease doc or cardiologist about a specific patient, reviewing echo results, reviewing perhaps with the nephrologist, the systolic hypertension responses, and we're spending 22 minutes of 30 minutes of travel time, but we're spending that 22 minutes on the phone for a patient, we can bill for that. We just can't bill for the travel time. Right. Any teaching, for those of you who do teaching in the office, that is general in nature, right? So if we're stopping in the hallway to talk with our student, resident, or fellow about the progression of aortic stenosis, and in general, right, that time wouldn't be able to be counted, but time spent discussing a specific patient absolutely would be able to be included, right? And so since we don't have to worry about all of this time being face-to-face, and we don't have to worry about qualifying it anymore with the greater than 50% of the time, right? We need to ensure we have a way to capture in aggregate, when we want to use time, all of the activities that were included in what we did and all the time that we spent, right? And so I'm a big fan of macros and quick text that will allow some simplification of this documentation, right? But if you're using an all-encompassing macro that's memorializing the activities on the day and counting time, it needs to be accurate. So if we're going to use a macro or some quick text or a copy paste function, right? It really needs to ensure, we really need to ensure that we're going in and editing it for what accurately happened today, right? And if we look at the example here, this total of 24 minutes spent prepping for the PIP visit, obtaining the history, performing exam, providing education to the patient family / other, ordering prescriptions, tests, or procedures, and documenting EMR. Well, that might look nice on first glance, but who did we actually speak with, right? Were there tests and orders for prescriptions or procedures actually done, right? And when it's or procedures, that's not a factual statement, right? So we really, if this was our quick text, right, we would need to go in and clean it up. And if it was only the family present, right, we would take these words out. If we didn't order any procedures, we would take that out, right? And make sure that it's an accurate representation of what was actually done, which right at the bottom is a little cleaner, right? Total visit time 24 minutes, reviewed the prior visit, patient intake form, obtained history, performed the exam, discussed with the patient, and ordered diagnostic test. Complete note of the EMR, right? These are factual items that we completed along with today's visit. I get the question often, are we required to capture the time spent in each activity? And the answer to that is no. We don't have to say that 10 minutes was spent in review and 15 minutes were spent over here and 5 minutes. You can get an aggregate time, right, that accounts for everything that was done in the day, total time of the visit, and ensure that we're accounting for some relevant components of what was included in terms of activities in those total minute counts. Right. And so as long as we're accurately representing what we did and for how long on the patient, we can count all of that time. Right. And if we look at the visit times, right, we can see that the amount of time we spend can quickly add up when we're accounting for it all. Right. And so if we had a patient that, again, from a complexity standpoint, and I'm going to review those rules in a moment, from a complexity standpoint, was a 99213, but we spent 10 minutes prepping, 10 minutes with the patient, and 10 or more minutes, let's just say 10 minutes documenting in the chart and writing orders, then we would be at 30 minutes. And that complexity-based 99213 should actually be a time-based 99214. Right. And so that's why I say we should use the time as a backstop, because we might have patients that aren't as complex from a complexity standpoint, but either they ask us a lot of questions, we had a lot of data to review, or the visit just took longer than what would normally be associated with a visit of a lower complexity level. And conversely, when we get to the medical decision-making component, we'll see that even if we happen to, in all of those time-based activities, right, only spend 15 minutes with a patient, if we meet the requirements from a medical decision-making component to get to a level 4, we would bill a level 4 based on medical decision-making, right? So we choose the code based on the highest level of substantiation we're able to account for. But if it's going to be time, we just need to make sure that that we account for the times. And again, remember, in 2024, the start and stop times should go away. That's what's in the proposed the proposed guidance from CMS, and we're expecting that to go away. And so it'll just be a flat, time that has to be met. It's probably going to be these minimum time thresholds, right? So from a time-based coding perspective, we want to be able to capture the total time of the visit. We want to be able to carve out any time associated with another billable activity. So if it took us 6 minutes to do an injection of a patient, we want to carve that out of the 36 total minute visit. It'd be 30 minutes for the E&M code. If we're doing another billable procedure, right, that we're billing a CPT code for, any time associated with that has to come out. But other than that, we want to capture all of the activities associated with the time we're spending on a patient. I'll pause a moment to see if there are any questions based on time before I go to medical decision making. Any questions? Okay. And again, when we're considering which code we're going to bill, right, most of the pushback we get from the doctors is, well, I don't keep a stopwatch. I don't necessarily know how much time I'm spending, and I don't want to start treating my patients the way my accountant or lawyer treats me. And so I don't want to worry about the time. And while I agree that in the overwhelming majority of most primary care doctors and specialist cases, there's going to be enough time spent to get to a higher level code from a decision-making component on patients where you're actively working through symptoms and managing components of their care, right? For those higher level visits, we can easily spend 40 minutes on a patient that we're managing something for an established problem. We can easily get to 40 minutes of time if we start adding it all up, right? And it's harder to get to a level 5 from a complexity standpoint than it is from a time perspective. So we don't want to miss out on dollars that we should be getting in the practice. So let's talk about medical decision making for a little bit before we wrap them both together. The elements for medical decision making, right, are made up of the components of the visit, represented by what problems we're addressing, what data inputs and outputs are we concerned with, and the overall risk to the patient. And we're going to break these down in a moment and go through the medical decision-making grid that the AMA has for us. Additionally, there are some definitions that apply, and you'll see them used in the grid. And so it's important to have an understanding of what they mean, right? Was on a call yesterday with a practice who is going through the habitual downcoding by United of their level 4 visits. And so going through the grid and outlining for them the opportunities to use, in kind of some standard appeals was helpful for them. So knowing the language and knowing how to point it out when appealing claim denials is important as well. So let's start with understanding the difference between problem lists and problems being addressed at the encounter, right? And the clinicians, your physicians and non-physician practitioners need to know this. A problem, as defined now by coding, is really anything addressed at the encounter. Because by the time you read through disease, condition, illness, injury, symptom, sign, finding, complaint, or other matter, it's something that's addressed at the encounter, right? So it might be addressed as a matter of, hey, I have this issue going on, right? I have this problem, I've been dealing with X, I have this condition. But that doesn't necessarily mean just because it was addressed at the encounter that it's a problem addressed to be counted for coding from a coding perspective, right? And so we're able to count the problem as an addressed problem when it's managed or evaluated by the treating healthcare professional, and they are evaluating the problem at least by history, exam, or diagnostic studies. It's not just they're being told there's an issue and they're sending them to another specialist, right? So a referral without evaluation does not qualify as a problem being managed or addressed by the physician. So what do we mean by that? So if we're a specialist and the patient is perhaps an HIV patient and they're running low on their HIV meds, and we say to them, well, do you have an appointment scheduled with Dr. Hussey-Whatsit? And are you all set to make sure that that's addressed? And they say yes, and you say great. Or if they're a diabetic patient with complications and we're a cardiologist, and they say, oh, I see Dr. K or Dr. Horowitz for that problem, and I have an appointment coming up. Or the cardiologist says, well, do you have an appointment coming up because it looks like your A1C is not where it should be, right? And they say, no, I'm following with the endocrinologist, and the cardiologist says, great, you should follow with them, and isn't really worried about it. That would be a referral without real evaluation, right? If for whatever reason you're the PCP and the patient is being managed by a cardiologist for, let's say, arrhythmia, perhaps they're on blood thinners, they've had a recent stroke, and they are out of their Eliquest and they don't have an appointment with their cardiologist anytime soon, and we visit the problem and write a prescription to get them through, that's evaluating or managing the problem, and that would be counted as a problem addressed. So important to delineate and ensure that the clinician is documenting appropriately in the assessment and plan or impression and plan components what is actually addressed and what type of evaluation or management was done, if we're needing to get credit for those problems being addressed, right? And many of our patients have a laundry list of problems. Doesn't mean we're addressing each of them. So a problem list and then having the specific problems from that list that are being addressed in the impression and plan is generally recommended, right? Here's one of the definitions that came out of the coding changes, and that's the way the word stable is used when addressing a chronic illness. So a stable chronic illness, from a coding perspective, is a chronic illness that has reached the treatment goal. If it is not reached, if the patient is not at their treatment goal, then the problem is not stable. Even if the condition has stabilized, even if the condition has not worsened, right? It is not a stable chronic condition. So I'll use a patient's A1C as an example. If a patient has an A1C that is 7.8, and the clinical goal is their A1C be 7.1 or below. And for the last 4 visits, it's 7.8, but when they came to see you originally, it was 9.2, and now it's stabilized at 7.8. And the goal, though, is to be at 7.1 or below, right? It's stabilized, it's not worsening, but it's not stable. So their diabetes wouldn't be a stable chronic illness if their treatment goal, right, was a 7.1. Same thing goes for albumin levels, for liver function levels, right? For anything that has a lab value or diagnostic value component, those are easy, right? Rheumatologists with evidence of disease, right, on imaging, those are easy. When there is not an objective measure that can be assessed through a diagnostic, then we need to set the clinical goal, right? And it may be that for joint tenderness and stiffness, that they are waking up with less than 4 tender joints, no more than 3 times a week, right? But we need to set that clinical goal and in order to be able to address it as stable. Same thing if it's chronic pain, we would say what we expect the clinical goal of the pain level is, and at what frequency or duration, and once they are there, it would be stable, right? But other than that, from a coding perspective, we don't count the illness as stable unless it's at a clinical goal. From the problems being addressed perspective, there can be multiple problems, of course, addressed at an encounter, and smaller problems as they are thought about in aggregate may indeed increase the overall risk. So one problem that is addressed that wouldn't necessarily be as problematic for a patient, right, compounded with other smaller problems, increases the risk in aggregate. That's I think counterintuitive and understood by most clinicians. The second area or element of medical decision making is data. That's the tests that are ordered, from labs to physiologic, to psychometric, to diagnostic, right? Tests that are ordered. Used to be the case that if you ordered 3 laboratory tests, right? A CMP, a liver function test, and an RBC, those were 1 point for you because you ordered tests in the lab section. Now it's each individual test that's ordered gets credit, right? Each individual imaging gets credit. External review of records. If you're looking at a patient that has come out of a recent hospital stay and you review 3 different consultative notes, right, from the different specialists who were on the case, those are external records that are reviewed, each of those, right? And the overall risk for a patient of high, medium, low, or minimal, right, is going to be fairly subjective, and we'll talk about that as well. The independent historian that you'll see is somebody that is required to provide information to your doctor because the patient is an unreliable historian. So it's not, when we see this term used, it's not because the husband talks over his wife or vice versa. It is meaning that the patient themselves can't give an accurate history because of their cognitive or physical status, and an independent historian is required. Right, so let's delve into these elements and see what accounts for the different types of medical decision making: straightforward, low, moderate, and high. And each of those can be pretty much attributed to a level of code, right? If there are 4 codes in a code set, like the home or ALF codes that have a 9924, 9341, 2, 4, and 5. Right? It's straightforward, low, moderate, and high. 1, 2, 4, and 5. If we talk about the office visits, 99212, 13, 14, and 15. Again, they align very easily with those. If there are 3 codes in a code set, SNF or hospital inpatient, right? It's going to be high along with the highest code, moderate, and then low to straightforward. So we'll talk about each of those as we go through these grids, right? The first element, low complexity, 2 self-limited or minor problems. What is a self-limited or minor problem? That is a non-venomous bug bite. That's a superficial rash. It's something that a patient can gargle with salt water, can just rinse away, maybe put some ice on if it happens to be a bump or a bruise, right? Stable chronic illness. Now we see that term, stable chronic illness. Stable acute illness. This is important because stable acute illness is different than stable chronic illness. Remember that stable chronic illness means a chronic illness that has met its clinical goal. A stable acute illness is an acute illness that has stabilized. So if I come in and I have an upper respiratory infection and I'm started on antibiotics and I'm told to come in to the office in, let's say, 7 to 10 days to see how those antibiotics are doing, right? I come in and that illness has stabilized. It's getting better. It may not be completely resolved, but I'm still taking antibiotics and it's doing what it's supposed to do. Would be a stable acute illness, right? As opposed to that stable chronic illness, meaning at clinical goal. From a moderate complexity perspective, it would be 1 or more chronic illness with exacerbation, progression, or side effects of treatment. So what does that mean? That means it's not stable. It's not at clinical goal. So 1 or more chronic illness, not at clinical goal, right? 2+ stable chronic illnesses, 1 undiagnosed new problem with uncertain prognosis, lump in the breast. We need to follow up and do a biopsy of something. Unclear as to the reason why the patient has had sustained weight loss, right? 1 acute illness with systemic symptoms, 1 acute complicated injury. So moderate complexity is going to be any one of these presenting problems, right? Problems addressed. Again, quite often the patients we're treating have 2 or more illnesses. If they're stable, then it's going to be moderate complexity from a presenting problem perspective. So that means if a patient has diabetes and hypertension and they're both stable for this first element, it would be moderate complexity, even though that's a fairly simple case for most of you that are treating those problems. It would be moderate complexity. Right? High complexity is going to be a chronic, 1 or more chronic illness with severe exacerbation, progression, or side effects of treatment. So if we're our involvement is helping keeping them from being admitted, readmitted, or severely decompensating to the point of threat to life or body function loss, right? The third element, we'll get to the second, but we'll skip to the third, the overall risk. Right, low complexity is going to be over-the-counters, physical therapy, home exercise programs, right? Moderate complexity, we're going to reach a lot of with prescription drug management. Remember, prescription drug management is not just increasing, lowering, starting, or stopping dosages. It is continue current course is still prescription drug management, right? This decision is being made to continue. You can see that in here are the decisions for surgery additionally, right? So if we're going to move forward for an orthopod, if we're going to move forward with major surgery without identified risk factors, so we've got a healthy 27-year-old patient who needs ACL repair. They have no other risk factors. There's nothing going on, no drug allergies, no other comorbidities. That would be elective major surgery without identified risk factors for that visit, right? And high complexity visits. Oh, I'm sorry. And from a moderate complexity perspective, the other one we see a lot that that can be substantiated is the diagnosis or treatment impacted by the social determinants of health. Social determinants of health are living status, psychosocial, it is socioeconomic, right? Those factors, if they are impacting treatment or diagnosis, if they're documented, can account for moderate complexity. So you may have a patient that isn't on prescription drugs, right? There's no reason to put them on a script, or they can't afford a script. Perhaps they're taking over the counters and that's enough, but their diagnosis or treatment is impacted by the social determinant of health. So they're short-term mildly depressed. They've had a death in the family. They've had a caregiver that was there to help with assistant transfer that's no longer there. Maybe they went back to school, left the area, right? It's important to document what that impact is and how it is affecting their diagnosis or treatment from a negative perspective. And if that's the case, it would be a moderate complexity visit, right? So 99214 or 04 if it were in the office. And then high complexity, harder to get to now from a complexity perspective. So it's going to be drug therapy requiring intensive monitoring for toxicity. We can use that on the date of service that we're actually doing some type of physiologic or diagnostic monitoring for toxicity of the patient, right? Elective major surgery with identified risk factors, emergency major surgery, so appendicitis, your cardiologist, and it looks like the patient has to be sent for a cath right away. It looks like we've got a impending heart attack, right? You've got parental controlled substances, decisions to de-escalate care or go DNR. It got a lot harder to get to level 5s for the overwhelming majority of the physician community, right? But there are definitely opportunities where level 5s absolutely exist in the mix, right? And so let's take a look at a couple of examples before we look at the grid. So in this example of a 99213 or a 99203, because remember the level of service is going to be the same whether it's a new or established patient, right? It's substantiating, right, the overall complexity level. So even if the patient is a new patient, it doesn't matter if the problem is established or not to the clinician involved in the care. It used to be the case that we had to worry about whether or not the clinician involved in the care was familiar with the problem or not before we assigned it, the level of complexity. Now that is not the case anymore, right? So the number of complexity and problems addressed in this case, so we've got a stable thyroid patient without complaint or change in test or exam. So that's one stable chronic illness, right? We looked at an ultrasound report. So the one test that's minimal, that'd be a level 2 type patient. And we have them on Synthroid. Stay on your current dose of Synthroid, moderate. So this one balances out. We've got moderate level for overall risk, We've got the level of data at 2, right, minimal, and we've got a low level for the presenting problem. So that's a level 3 type patient. You can substitute in any chronic illness here, right? It can be arrhythmia, it can be CHF, it could be rheumatoid arthritis, it could be any diagnosis you want from a chronic illness perspective. If it's stable and it's 1, and that's all we're doing today, right? It's low complexity, which means that if there was one other thing going on with this patient, if they were also hypertensive and they were stable with hypertension, then this would go up to moderate, and this would be a level 4 type patient without anything else changing, right? Let's look at another example. We've got stable hypertension and diabetes. So 2 stable chronic illnesses, to my point, level 4 type patient, moderate complexity. Amount or complexity of data to be reviewed, a CMP and CBC, that's limited. It was only 2 tests, not 3, right? If it's 3 or more, it would be moderate. And then prescription drug management, we're going to stay on the same dose of the antihypertensive and oral hypoglycemics. So continue your current dose of medications. Is going to be moderate. So these happen every day in our offices, and far often we still see physicians and non-physician practitioners billing these as level 3s, sometimes even level 2s, because they're so fast for them and they seem so non-complex, right? But the rules state we can have these be billed as moderate complexity, indeed be billing them as such, right? Next example, level 3, doing well, no joint pain or swelling, tolerating the meds. This is what was billed, was a level 3. This is a rheumatologist, right? What did they do? They planned, their orders were a CRP, sed rate, CBC with diff, and a CMP, and they wanted to put the patient on methotrexate, folic acid, continue that care. So this was billed as a level 3. What should it be? Well, it is a level 3 from a presenting problems problem address perspective, but from a data perspective, there were 3 unique tests that were ordered and reviewed. So that would be moderate, that'd be a level 4, and prescription drug management is a level 4, right? So this visit it was looked at. These were, I would say, live, right? Impression and plan, assessment and plan components pulled from a recent chart review. And this physician in question was habitually undercoding, right? OA of the knee, OA of the right knee still with pain. Consider MRI, Aleve, Voltaren gel, and physical therapy, right? We should all be in agreement now that the OA of the right knee still with pain would not be a stable chronic illness. So it'd be moderate complexity. This is going to be limited, right? Because just 1 test is minimal. And over the counters, physical therapy, low overall risk for the patient, right? This would be a level 3 visit. COPD with shortness of breath, no data, and continue bronchodilators and O2 as needed. Well, COPD with shortness of breath, non-stable, no data. Moderate complexity from an overall risk perspective. We see these in the hospital all the time, as well as in the office. So it'd be moderate complexity, so a level 2 right in the middle for a hospital visit, and then a 99204, 99214 type patient in the office, right? Any questions on the coding from a medical decision-making perspective before I get into some of the highlights on the proposed fee schedule rule? Okay, so from a proposed fee schedule rule perspective, the conversion factor, as I'm sure you all have read or seen in professional guidance, is going to be $32.75, right? Understand that that's an overall. The recommendation is always, once the final fee schedule comes out, take your top 20 codes that make up 80% of your reimbursement, throw them in an Excel sheet, throw the new reimbursement rates on there to see exactly how the new fee schedule is going to affect your business, right? Even if nothing changing, did the same amount of services from year over year, at least know how it would affect the bottom line. Split and shared visits for evaluation and management services. So folks that are seeing patients with both a doctor and a non-physician practitioner in the inpatient setting. It's going to be important to make sure it's clear who rendered what component of the visit in order to be able to bill under the doctor and get the full reimbursement. So make sure that at least through the next year that your documentation makes it clear who did what, not just that the doctor is signing off on the note, right? Telehealth services they're going to continue to be paid at the higher rates, the non-facility physician fee schedule rates, just like if patients were seen in the office. Make sure you're using the right place of service and modifiers. One of the nice things that came out of this push for remote supervision is that at least through 2024, it looks like physicians are going to be allowed to provide direct supervision through real-time audio and video interaction. So that means for any services that require direct supervision, that means in the office suite, right? You can do so by having a real-time audio-visual interaction set up. I know a physician who's having Google Nests put into their infusion suites, Google Nests put into the rooms where they don't have real-time audio-visual capabilities. And it's not a plug for Google Nest, it just happens to be what they're using, and is going to be able to leverage, right, the direct supervision component being met by audio-visual when they're not in the office, not having to shut those things down because they don't have the appropriate supervision requirements. Remember that the state of Florida revised its rules on direct supervision to mirror what Medicare allows, so we don't have to worry about Florida law with that as well. The telehealth services are going to be, for the most part, continued through 2024. I expect a couple of revisions in the final fee schedule rule when it comes out, but for the most part, you can continue to render telehealth services the way you have been, right? MIPS reporting thresholds for performance is going up to 82 points for the reporting options. I do know a practice in the South County area that is having a greater than 6% increase to their reimbursement because of their wonderful performance with MIPS. So don't write it off as something that is just a cost. It does still pay off at times to be participating with MIPS quality reporting. Couple of quick things that are important to keep track of: the drugs and biologics that are not usually self-administered, right, by patients that are, usually self-administered by patients, right, and getting administered in the office. Please know that there should be some comments in the final rule about whether or not CMS is going to continue to either make exception for or find ways to exclude any payment for Part B drugs that are usually self-administered. So hopefully those of you who this will affect commented on the rule, but expect that it to be something that they are continuing to study, if not making changes to starting in 2024. They are really trying to crack down from the perspective of practices that are finding ways, and I don't mean that in a bad way. It might be absolutely legitimate ways to administer drugs to patients because they might have some type of genetic and or physiologic abnormality that doesn't allow them to self-administer the drugs, right? CMS has seen a significant uptick in those, and so they are what I would call cracking down on that. Some of you might have heard of appropriate use criteria. If you order advanced imaging, know that that is going away, and so we don't have to worry about that. That was a nice sigh of relief for the diagnostic imaging centers, and for those of you that do advanced imaging in your office, the requirements that had been I'll call threatened to be put in place over the last few years went away. A couple of other interesting components. So the provider enrollment statuses, right, are being affected. There are going to be some regulatory provisions that Medicare is going to put in place that have really been the result of fraud and maybe more accurately termed abuse and abusive actions. And so Medicare is going to start to use stay of enrollments when they think there might be a provider that is caught up in an investigation, rather than just suspending or deactivating, so that providers, when they are able to prove that they haven't done anything wrong, are able to quickly get back into the system without having to start from scratch. The changes, additions, deletions, changes to locations are going to have to be reported within 30 days, or you could run the risk of having your Medicare number deactivated. There are going to be a few additional denial and revocation authorities provided. So what Medicare has been seeing, and what the OIG has been reporting to Congress, is that Medicare keeps allowing bad actors to continue to participate in the program. And they're trying to crack down on that. The Medicare and Medicaid enrollment processes are being put in line so that they can keep the bad actors out longer. The good news in the fee schedule, or some of the best news, if you will, is the G2211 code. It looks like this will finally be put into effect. This will be specifically added on to evaluation and management service code visits when the visit complexity is high, right? And so when we have a clinician that is the focal point for all needed healthcare for patients' ongoing either single or serious condition, and it's complex, the add-on code for G2212 would be payable in addition to the office visit code, right? And the office visit code would need a modifier 25, but it is anticipated that an overwhelming majority of primary care providers will have the ability to use this increased visit complexity code, and which will result in additional reimbursement. There's also a proposed social determinant screening code, but there isn't enough information out on it currently to include. Again, look for that final rule to be published quickly. And on a final note, you may or may not be aware, this is not part of the physician fee schedule, but this is a Florida specific issue. The Florida Electronic Health Record Exchange Act was signed into effect with a, I believe, July 1 effective date. It now requires, from home health aides to physicians, physician practices, any healthcare provider using a EHR to ensure that the only off-site physical or virtual environment that your data can be housed on from a third-party, direct or subcontracted vendor perspective must be maintained in the continental United States, its territories, or Canada, right? It means offshore storage of data is not allowed from a statewide perspective, right? Not quite sure how this is going to play out with other states in the union, as there are some states who already have laws like this in place. Some have more or less stringent requirements. I'm assuming Governor DeSantis and the Florida legislator kept Canada in to keep our snowbirds happy. But if that information is kept outside of the continental United States, its territories, or Canada, you have a problem, right? And so you're required to sign an affidavit at the time of any license renewal or any initial application. So for those of you hiring fresh new providers, fresh new license providers, and or renewing licenses, know that the affidavit has to be signed and accounted for, and disciplinary action might be adjudicated, probably will be adjudicated should a problem arise. So you really need to do a good job of understanding where your EHR vendors, right, are keeping information. From the backup to billing companies to coding companies to cloud computing, right? Where are they keeping the information? Where's their backup solution? Do they retain information? If there's anything offsite, right? How is it transmitted, and where is it stored? These are all components that could come back to bite the practice in the rear if you're not proactive on this. Again, coding changes happen every year. Please make sure you read the parenthetical notes and guidelines. It's the best way to understand why. Share the information with your docs and non-physician practitioners and educate the coding and billing staff. There are tons of trends that happen in relation to these fee schedule changes. Monitor for those, look for denials. United is again up to some shenanigans, denying level 4 visits across the board for a number of specialty types. And do what you can to ensure that the practice has the most healthy and efficient way of ensuring its financial stability. Any questions? Mindy, I'll turn it over to you.
No.
I don't see any hands raised.
I don't see any hands either, Chris, because you're so thorough that they didn't have anything to ask about.
I hope so. I hope I didn't put him to sleep. So if you
No, you
guys have,
didn't.
if you all have questions that arise from this, please feel free to send them to Mindy. She'll get them to us. We're happy to answer them. We do a lot of work in support of the medical society, so happy to answer any questions that come up later.
Oh, we have a question. Can you please expand on the G2211 code?
So the information that tough to expand on a code that hasn't been finalized yet. So what the expectation is that a patient that has what's considered a serious or complex condition, that's a heck of a lot of conditions fall under that umbrella, that's getting managed by a single point of care that's kind of quarterbacking the patient's needs, that those clinicians will be able to bill that G2211 code. Now, as currently defined, it's only for use in the office or other outpatient setting. So the 99212 through 992 15 for established patients and 99202 through 05. And it's expected that, I know when this came out in the 2021 fee schedule, it was expected that the overwhelming majority of primary care doctors would be using this code on 80+% of their visits to manage these problems. So I would expect CMS, when this is finalized next week, to have a ton of guidance on this code as the year closes. I expect the current administration to put out their fact sheets, and I know that we'll be working in collaboration with Mindy and the Medical Society to get information out as the rule is finalized. So it's really just meant to be an add-on code to account for the additional work it takes to manage serious conditions, right? So for argument's sake, if you were just managing, and I use the word just, but I don't mean it to put anyone down. If you're just managing tinnitus and it was an acute issue, right, that wouldn't be something that would have this add-on code. If you were managing an acute upper respiratory infection, and that's what the patient came in for today, it wouldn't be that this add-on code would be used. But if the patient had something more serious or chronic, if that had some long-term repercussions, and even if it was short to long-term that you were quarterbacking through the practice, you'd be able to use this code. And again, there'll be a ton of guidance coming out once the final fee schedule drops next week.
Any other questions?
Wonderful. Well, thank you, Mindy, for having me. Always a pleasure. And for those of you that are familiar names and faces, nice to see and read the names. For the rest of you, have a wonderful closeout to this hectic year we've had.
Thank you very much, Chris. It was very informative presentation.
Thank you.
Have a good day, everyone. Thanks for attending.